consultant nephrologist from KMCH will be the chairperson. Sir, you're not audible, sir.
Hello. Dr. Ravichandran sir requests no introductions, and he is popularly known for our nephrology updates, WhatsApp update groups. I invite him to talk on the codependent functions of heart and kidney normally as well as in diseases.
Thank you. I welcome all delegates and thanks the Novartis for giving me this session and the organizers for giving me the time to talk on cardiorenal syndrome. So kidney conundrums in patients with heart failure is growing much faster, especially with focus coming in. Let us start with a patient's case scenario. This is a 64-year-old man with CKD, eGFR 37, mild proteinuria, presents with new dyspnea on exertion and lower limb edema. The question is, what is the likelihood that this patient has heart failure, or is his presentation related to his CKD? After admission, we do a BNP, it comes at 1354. Does this help in our diagnosis of heart failure? So routinely we start with diuretic Lasix and his weight comes down, he diuresis, but his creatinine goes up from 2.2 to 2.6. So this is a common scenario we face every day. So why is this happening? How are we going to explain? Cardiologist and nephrologist comes in and each have their own domain. So let us see the epidemiology of heart failure in patients with kidney disease. So normally what we read is, when there is a CKD, we want to delay progression to ESRD. But the statistic shows that the death from CVD is much more than waiting or progressing or allowing the patient to be on CKD. So whether we need to worry about patient going into ESRD or whether we need to worry about saving him from death due to cardiovascular disease. So heart failure is one of the most common type of cardiovascular disease in patients with CKD, and excess risk of CVD in CKD patients largely explained by heart failure and CHD. CKD patients have 3 times higher risk of heart failure compared with non-CKD patients. So this becomes very important that we need to assess and find out if all our CKD patients do have heart failure or not, because impact of coexistence of both heart disease and kidney disease leads to more hospitalization. Not only that, the moment we discharge, like our previous speaker has told, rehospitalization is common. There's a need for intensive care, which increases the cost of therapy, and patient is usually unaffordable. And then we push them into renal replacement therapies, or if it is end-stage cardiac disease, go for heart transplant, and death is inevitable. So we need to understand what is this complex bidirectional relationship between CKD and heart failure. So as long as heart and kidney are functioning normal, it's two entity. The moment one fails, we no more call it as single entity, we call it as a cardiorenal syndrome. Injury can be in the kidney first or in the heart first. So each one has a definitive spillover to other one because of its bidirectional relationship. And this relationship is usually connected either by hemodynamic mechanism or cardiovascular disease associated mechanism like your FGF23, chronic inflammation, malnutrition, or bone mineral disorder, acidosis, or anemia. And most important one, which keeps this trigger going on and becomes a vicious cycle, is the neurohumoral mechanism, which is activation of the RAS and sympathetic nervous system. So any one organ which is deranged, automatically the humoral mechanism is activated, and it is not a single event. It becomes a vicious cycle. So here we have two systems where RAS keeps filling, and if the heart doesn't pump it out, emptying, it is done with the BNP. So there is a more and more supply of natriuretic peptide. Unfortunately, whenever there is inflammation, the kidney puts up a lot of nephrolysis enzymes which break down this BNP and doesn't allow the natural mechanisms to work through. So heart failure disrupts normal kidney function and leads to cardiorenal syndrome that further promotes heart failure progression. Now, one interesting thing which happens, we fail to understand, is we have a central nervous system and a peripheral nervous system. Similar thing happens in the kidney where there is an intrarenal nervous hormonal mechanism which is controlled by the angiotensin II mechanism. And once this is stimulated and the central mechanism is cut off with heart failure or in CKD, there is a progression. So the renal cells and inflammatory cell comes into play. Proteinuria, extracellular accumulation, matrix accumulation, cell proliferation, and inflammation all lead to progression of the disease. So our job is, how are we going to intervene? This interesting article which shows that the intrarenal neurohumoral modulation by renal denervation benefits chronic renal disease and heart failure. So basically, when we are cutting off the central mechanism from the peripheral renal intracellular mechanism, we are able to manipulate a lot of things and able to protect the kidney from fibrosis. So this is another additional intervention nephrology which can be focused more, whether this could be a future role for the nephrologist. The problem with heart failure is a clinical diagnosis is very difficult to know whether it's a kidney disease or is it due to heart disease, because symptoms coexist. And that's the reason why they brought out this Kansas City cardiomyopathy score, where when this score was put in, it was seen that 40% of the CKD patient who did not have symptom had a subclinical heart failure. So they brought in a new entity called as pre-heart failure. That means heart failure which is not visible but could be found out with this scoring, and CKD patient with the highest burden of heart failure symptom had 3 times higher risk of incident of heart failure within 1 year. So epidemiology, to summarize, heart failure is very common in patients with kidney disease due to hemodynamic, neurohumoral or other mechanism. Development of heart failure is associated with poor clinical outcome, including faster progression to end-stage renal disease and death of patients with CKD not approaching end-stage renal disease, and CKD patients with early symptoms such as dyspnea on exertion and edema are higher risk of developing heart failure. Now, how are we going to interpret the cardiac biomarker? So whenever there is a raise in NT-proBNP, it is an indicator that there is a heart failure, but a progressive raise definitely shows that there is a heart failure. So every patient CKD, it is advisable to at least document one one report of NT-proBNP, because looking at the BNP, the sensitivity and specificity in non-CKD patient with cutoff of NT-proBNP more than 450, it's still 85 and 88. But when it comes to CKD, NT-proBNP threshold of 1200 is necessary to interpret BNP values. Even then, the specificity is only 72% and sensitivity 89%. So we need to know what is the use of these biomarkers, and it's not very helpful in CKD, but still raising in these biomarker progressively, even if the patient is asymptomatic, is very important. And creatinine, as per current AHA guidelines, is not recommended as a serial measurement, is not a best measure for kidney function to guide heart failure management. So we need to ignore this creatinine, because most of the nephrologists, whenever we see creatinine going up, first thing we do is stop ACE inhibitor, which becomes more disastrous to the patient. And we need to find alternative to creatinine to see what is the better way of guiding our therapy. Of course, biomarkers are very expensive or not routinely used, and by the time we use creatinine, BUN or NGAL, already the injury has set in, which is in the last stage. So, summarize the application of cardiac biomarker. Elevation in BNP is likely reflects cardiac pathology, but don't ignore them. Progressive raise in this biomarker is definitive risk for heart failure, even if the patient is asymptomatic. It is unlikely that traditional cutoff can be applied in patient with CKD. Ongoing work to develop CKD specific cutoff. So there are still biomarker problem going in, but still we can't ignore the raise in biomarker. Now Important situation is when a stabilized patient, suddenly they go in for derangement, maybe acute kidney injury in a hospitalized with heart failure. And again, the derangement occurs whether it's a decompensated heart failure or injury to the kidney, both organs are deranged and entire problem starts because patient who is already on ACE inhibitors or anything, nephrologist or cardiologist worry to give the drug, or they try to withdraw MRAs because of hyperkalemia. So AKI is associated with poor in-hospital and post-hospital outcomes. They have higher mortality, higher rates of CKD and progression to ESRD. Diuretic resistance is very high whenever AKI develops. They have a longer length of stay and higher rates of readmission. So directly it affects the treatment because we are apprehensive in starting RAS inhibitors, MRAs, and diuretic standard of care. Kidney function may affect efficacy and safety, and kidney function may affect initiation and dosing and discontinuation. Very confused. Some centers will use ACE inhibitors, others will never use. Diuretic giving or not also is confused, as in our patient, the moment we gave diuretic, the creatinine jumps. So all these conundrums comes into the picture whenever the patient in ICU and we get a call from the cardiology unit. This interesting study showed that if creatinine is coming down with AKI earlier, they do bad, and similarly if creatinine progressively goes up, those patients also do bad. So diuretic study in AKI shows that both improvement and worsening of serum creatinine are associated with poor clinical outcome in acute decompensated heart failure. And that's why creatinine is not a useful biomarker, and most of us should not be using creatinine as a marker to stop ACE inhibitors. Now, how do we manage cardiorenal disease? So 4 pillars foundation therapy for optimal management is RAS inhibition, beta blocker, MRA, and SGLT2 inhibitors. Now there is a problem between ACE and ARNI. ARNI is a dual blockade system where sacubitril is a prodrug and valsartan is AT1 blocker. So we already mentioned that intrarenal mechanism is the one which perpetuates and continues this final disease which prevents BNP to act on the kidney. Here Novartis has brought down this ARNI where valsartan binds to the AT1 receptor, and that is this site that the nephrolysin inhibitor works and inhibits the enzyme which doesn't allow BNP to break down, which results in natriuresis and better fluid removal. Now SGLT2 is also coming into picture, and we had already discussed about MRA. So Paradigm HF has clearly shown a benefit of sacubitril valsartan over enalapril, and it is proven to be good for even renal failure patients. So across the serum creatinine values, we have been using it, and it has shown a good results. Similarly, NT-proBNP values has shown definitely to come down with sacubitril valsartan much more than enalapril, and Pioneer HF study has shown a significant decrease in NT-proBNP. Now, this is for reduced ejection fraction, but most of the patients have mid-range ejection fraction. That means it's between 40 to 50. So most of us will know that when CKD patient come, once they are diuresed, again their ejection fraction improves. So HF-MREF, that is mid-range ejection fraction, is an entity. And here this drug works very well. Vimedab at this patient showed a 13% improvement in eGFR in mid-range ejection fraction patient with CKD. So there is an improvement in GFR, which doesn't happen with other enalapril or any other ACE inhibitors. And it also improves the ejection fraction. So whenever there is an improvement in the ejection fraction from 49 to 55, again there is an improvement in eGFR, and patient with CKD are benefited, which prevents them from progressing to ESRD. So sacubitril valsartan is very useful in these patients where it is mid-range ejection fraction, and also there is a 41% reduction in the risk of hyperkalemia. Hyperkalemia is a very tricky subject, which is one which inhibits most of the cardiologists in using these drugs, but whenever we as nephrologists stretch on up till 6 and try to play our game giving these drugs. And again, sacubitril valsartan scores over ACE inhibitors. So ACC 2022 guidelines have clearly shown for mid-range ejection fraction heart failure to start with diuretic if needed, switch on to SGLT2, ACE inhibitor or ARNI, which is important, and MRA if potassium is stable, less than 5.5, and beta blockers. So there is a significant role of combining SGLT2 plus ARNI, and since SGLT2 also has an effect on RAS inhibition, oxidative stress reduction, sympathetic nervous system inhibition, and also its role in reduction in inflammation and also prevention of fibrosis and stabilizing the erythropoietin secreting cells, which is also an important function of SGLT2. So can we be more precise in heart failure? So until now, we are still in first line guideline directed medical therapy. We have not gone into precision medicine because we do not have much more biomarkers, and newer molecules are coming in, especially to manipulate the mitochondrial system and other drugs, which will be more discussed in cardiology clinic. So today what we want to know is, do not wait for the heart failure symptoms to come in. Try to pick up these patients as pre-HF, which is called, don't wait till heart failure sets in. Once it sets in, there is no reversal. It's like a microalbuminuria. Don't wait for albuminuria. You have to react at an early stage, and that is the golden window period. And how does it happen? And there is another entity which is called as a preserved ejection fraction. We see more in the aged population. And here nothing works. So the only drug where it is proven is SGLT2 inhibitors. And most of us keep on adjusting the dialysis, like our previous speaker also said. It's so restrictive cardiacs that transplant is the only option finally. So this is a DIAMOND study which has brought in a role of optimizing heart failure management. And what we learned from DIAMOND study is enabling RAS inhibition therapy, use of partriomer, which allowed more patients to be on maximally tolerated guideline recommended dose of RAS inhibitors. So potassium management and use of RAS inhibitors is very important. It's good that most of our nephrologists should not withdraw enalapril. They may switch over to ARNI rather than stopping enalapril, because most of the cardiologists keep complaining. First thing nephrologists do is withdraw ACE inhibitors. Key takeaway from DIAMOND study was, it's very clear from DIAMOND study that if we can use partriomer, we can use one of the 4 pillars of approved drug, either MRA or ARNI, which is a very good indicator for improvement for heart failure patient. Now the new department is coming up, which is subspecialty cardio-nephrology. So why this is important, cardio-renal unit is, cardio-renal unit can get reference from primary care, hospitalization, nephrology, renal replacement therapy, nephrology outpatient, emergency room referrals, internal medicine reference, cardiology outpatient reference. So everybody can refer to single unit. Without that, what happens is, from emergency, patient don't know where to go with 2 creatinine and heart failure, whether it's nephrology or cardiology. So this study has clearly showed that when the patients are referred to cardio-renal unit, there was a 10-fold decrease in heart failure hospitalization rate. So this new subspecialty is picking up very fast in Europe, and it should also come in our countries. And another, just before conclusion, we should also look into renal transplant and cardiac disease, because this is not much discussed. And we all know this, a single kidney EGFR doesn't go beyond 50, and whenever there is a rejection or any fall in EGFR, automatically there is a trigger for heart failure and the disease progresses. So cardiovascular risk and kidney transplantation is also getting recognized, and we are also using in these patients nephrolysin inhibitor, and in these patients immunosuppression and rejection infection becomes an added burden which we need to understand and talk more about, even heart failure in transplant patient. So to summarize, we have to initiate sacubitril valsartan in HRF patient with renal dysfunction at the earliest. Do not wait for good. Previously it was told, let the patient stabilize, then you start. Now it is, you start, decide when to withdraw, start reducing the dose. Even dose of 50 milligram half BD also saves life and reduces the hospitalization rate, because It reduces rate of EGFR decline, lower the incidence of elevated serum creatinine, lower the incidence of hyperkalemia, reduces incidence of worsening of renal failure. All these benefits of ARNI overrides ACE inhibitor. Thank you for giving this opportunity.
Sir, you're not audible, sir.
So do you use diuretics and ARNI together or serially you add one by one in hospitalized patients?
Diuretics, by the time the patient comes from emergency, already it would have been gone into the patient. But what we usually do is, if the patient is already CKD and the creatinine jumps to say 6 or 7 or 8, we prefer to do ultrafiltration so that the more the lung is dry, the better we can manage symptoms. Diuretic, slowly we are coming down on it, almost a very limited dose, but we prefer to use SGLT2 along with ARNI at the earliest. And NT-proBNP gives us the guide with patients who have got 35,000, 40,000 who do not respond. So each patient has a different kind of presentation.
Any questions from audience?
Sir, Dr. Kandasamy, may you please honor our speaker, Dr. Ravichandran P, with a memento.
Since we are going to start the inauguration